Thank you. And good morning, everyone, and welcome to this discussion. As already been noted, I'm sort of joined by a lot of members of our joint team with Philadelphia Fight and the Beat HIV Collaboratory, which is a coalition of investigators both here in Philadelphia and across the globe that are all engaged in advancing the HIV cure agenda. And part of that agenda means to be in communication with all of you and with transparency and clarity about why we are proceeding with the research that we're proposing, as well as considerations for anyone that wants to learn more about how cure research moves forward. So the next slide, I don't have the slides, so if you can advance them for me, that would be great. Thank you. These are all the individuals that are in the panel joining us today. I'm going to introduce them, and then I'm going to join for questions at the end. And since already all of them have been introduced, we can move forward to the next slide. So the objectives of today's discussion is really to put in context the work that we have been engaged for over 25 years and why we are at a critical point in this journey at this moment. Specifically because we want to define our activity regarding how it's getting us closer to a potential cure. Now, obviously, I want to confirm that a cure is not available for HIV, and the work that we're doing is moving us closer to that goal, but moving is our objective, that we want to keep moving closer towards that goal. So we're going to be talking about that today, and we're also going to be talking about a component of cure-directed research, which often includes an analytical treatment interruption, which, as you know, standard of care, or when you go to the doctor, you're basically told very emphatically to stay on your medications. However, by staying on your medications, you hold the viral from replicating. So a lot of the HIV cure-directed research tries to come up with strategies that basically try to take the virus away. So one of the few ways that we know can tell us whether what we're doing is useful is stopping antiretroviral therapy. So we're going to be talking about that, and we're going to be talking about what that means and how safety is included in the design of trials to try to prevent any bad things from happening. We're also going to be joined by as members of the community and that are going to talk about their experience as well as what it means to be in a cure study. Next slide. And I think today's discussion and the research that we're going to talk about is really the outcome of a long-term partnership between Philadelphia Fight and the Wistar Institute, which I've been honored to be part of. And here you can see just one highlight. We've had many instances to celebrate our partnership and honor people that guide us outside of Philadelphia. And this is Dr. Francois Barré-Sinoussi, who got the Nobel Prize for Discovery of HIV in France, in the Pasteur Institute, and she, as many others, have come to join us in reviewing our progress and reviewing our path forward. And I think that today's discussion and the research that's about to start is by far a culmination of this path. So we're very excited to be telling you about it. Next slide. So as I said, we've been working with Philadelphia Fight for over 25 years, and some specific some specifics are called for. Like, for example, we've been hosting community engagement activities for every year for over 25 years. We've been able to report to the scientific literature, over 32 reports over this period. And we've also been able to move data that we work on together here in Philadelphia to be the basis or the reason why other trials are being done elsewhere in the world. And that happened in sub-Saharan Africa, and we're now actually about to initiate trials in Vietnam that come from data that was actually generated here in Philadelphia. But most importantly, we've also used our partnership to leverage a large coalition, which is the Beat HIV program, which seeks to advance research for a cure. And again, all of these opportunities and all of these advancements come from the product of discussions like what we're doing today, which is outlining our goals telling you why we're doing what we're doing and working together to complete that goal. And once we complete it, then the fruits of that are very much a component of taking that information out of Philadelphia for the advancement, not just of our work, but the work that happens all around the globe. Next slide. So I think that we'll start with Andrea's maybe putting us in context of what does it mean to be working on HIV, towards an HIV cure, and to the community and to all of us. So Andrea.
Good morning. Good morning. My name is Andrea Harrington, and being a person who has lived with HIV for a long time, it's become, I guess you could say, a second person in my life. A cure would actually mean less responsibility for me to have to take care of someone else, if that makes sense. This HIV is something that sits on your shoulders. It's a hindrance. It's something that is a threat. It is something that is so unpredictable. And the cure would mean less anxiety for myself, less anxiety for our people. It would also mean less of a, how can I say, danger, because at any given moment, HIV, if not taken care of, can destroy. And not just physically, emotionally, financially. And a cure would actually mean that our community would be able to put aside fear, at least for one thing. We have so many things in our community that is that challenges us, that is hindering us, that is holding us back. And the cure for HIV would mean that our community would be able to thrive even further without one less hindrance. And it would be so wonderful. Thank you.
Good morning, everyone. It's my pleasure to welcome you, and we do appreciate you taking the time to joining our webinar today. My job is to tackle two important questions. The first daunting question is why cure for HIV is so hard to achieve. Well, the most important and major barrier for a cure, as we know, are the latent reservoirs. These are the sanctuaries where HIV hides, and really these are the places where it cannot be reached by either our antiretroviral therapy, and it's not detected by our immune system. As you all know, HIV has a very high predilection to infecting CD4 cells. And what it does, as soon as it enters these cells, it embeds itself in the DNA of these lymphocytes, and it becomes really an inherent component of the buildup of these lymphocytes. And this is really the point of no return. It becomes part of their ID. Not only does that, what it does also, it hijacks the machinery of these cells to produce progeny virions. One virus enters the cell, and hundreds to thousands of viruses will exit the cell, and they will go on to infect other CD4 cells. And when they do that, they end by destroying the CD4 cell. And as you know, the CD4 cell is the chief orchestrator of the immune response. And that's how it really undermines the immune system of our patient. What we know is that a very small subset of these CD4 cells will go on to a resting stage. Now, the vast majority of these cells contain a defective HIV DNA. So it really has no consequences. But a very tiny little fraction, 1 in a million, contain the full sequence, the full genome of HIV, which means that these cells contain an HIV-competent, replication-competent virus. Those are the cells that constitute the big bulk of our latent reservoir. These are cells, when activated, they can start spitting out HIV virus, which can literally recontaminate and start the whole vicious circle from scratch. So what do we know about these latently infected cells?
A little too high. No, don't leave the meeting. Yeah, that's okay.
So what do we know about these cells? What we know are the following. These are primarily CD4 cells, but they can be some other kind of cells. They can be monocyte, macrophage, but predominantly they are CD4 cells. These cells really, they're established within a few days from the acute infection, and that's underscore the importance of starting antiretroviral therapy very early on during the acute infection, because we can limit the size of these reservoirs if we do so. And unfortunately, these cells tend to persist indefinitely. As I mentioned to you, they escape both antiretroviral therapy, novel or antiretroviral therapy, conventional antiretroviral therapy, and they escape the immune system of the individual. So you can imagine these cells are dispersed all over the body. They are in different sanctuaries. They can be in the brain, they can be in the lymphoid tissue, they can be in the bone marrow, they can be in the GI tract, they can be in the genital tract. And really, if we want to eradicate HIV and cure HIV, we have to go after these cells in each one of these sanctuaries and really purge them out. As you know, it's looking for a needle in a haystack. It's almost mission impossible. But it's not really mission impossible. And the reason is, so far we know of 2 cases that were able to be cured from their HIV infection. The first one is Timothy Brown. As you know, you all know about him. He visited us many years ago. Tim Brown was cured in 2007. And the second patient who was able to be cured from their HIV infection is the London patient, cured in 2017. So I'd like to share with you is, what are the lessons we learned from these 2 patients who we were able to cure? Again, 2 out of 40 million people infected worldwide. But what are the lessons we learned from these 2 individuals? Timothy Brown had a leukemia. He was treated and failed. Obviously, he was living with HIV, had AIDS. He underwent a first round of stem cell transplant, which failed. Then he underwent a whole body irradiation followed by a second round of stem cell transplant, bone marrow transplant. But this time it was from a donor that had the CCR5D32 homozygote mutation, which means the donor that donated this bone marrow to Tim had this mutation, which rendered their R5, which are the gates that allow the virus to enter their lymphocytes, it rendered them resistant to HIV infection, refractory. This is very rare mutations, but when they exist, they render the CD4s refractory to HIV infection. You don't get it. Tim developed a graft versus host disease shortly after the bone marrow transplant, and his antiretroviral therapy was discontinued at the time point where he was fully undetectable. And then he was followed for 13 years of antiretroviral treatment. His virus remained undetectable both in his bloodstream and other sanctuaries. The second patient is very similar to Timothy Brown, the London patient. The London patient had the lymphoma. He was co-infected with HIV. He had a mild chemotherapy followed by a stem cell transplant, again from a donor with the CCR5D32 homozygote, resistance to HIV. This was in 2017. He also mounted a small graft versus host disease, which means that the bone marrow really took. And then he was undetectable on antiretroviral therapy. And then again, we discontinued antiretroviral therapy. And this patient now has been off treatment for 30 months. There's absolutely no virus in his bloodstream. And there is no replication competent virus in any of the sanctuaries we sampled. We did find very defective genetic debris of HIV in some of the lymphoid tissue, but they are inconsequential, as I had mentioned to you. So the common denominator among these 2 patients are as follows. And the lessons we learned are the following. 1, HIV cure is possible. But the second important lesson is that in both cases, we had to interrupt treatment to fully assess and test the efficacy of the intervention on HIV reservoirs. which leads us to state that analytical treatment interruptions today are the only way to prove the efficacy of any viral eradication / any suppressant strategy. We have to stop antiretroviral therapy to test the efficacy of our intervention and see if the virus is going to rebound or not, and be able to see the full impact of this intervention in the blood and in these sanctuary reservoirs we have mentioned earlier. So that brings me to talk about the second part of my presentation, which is, as you know, treatment interruption constitute an ethical dilemma. On one hand, it's very critical for us to really fully understand the impact of this strategy. But on the other hand, it's not supported by any guidelines. And as Louise said early on, we as clinicians, we've been preaching to our patient not to stop their antiretrovirals. Once they start, they need to stay on it. And we've been preaching 100% adherence. So how can we reconcile between the two? So what I would like to do is I would like to walk you through a strategy where we can implement ATI without really exposing our patient to high risks. So what are the different points I'm going to touch on during the second part of my presentation? I'm going to cover the risks associated with ATIs. Very briefly, who are really the appropriate participants for ATIs, who are at the lowest risk of having any bad outcome from ATIs. How do we monitor ATIs? And when should we really restart antiretroviral therapy when we are monitoring people off their antiretrovirals? So the first and most important thing to know and acknowledge is that going off treatment is a very stressful situation to our patients. It leads to a tremendous amount of anxiety, having to stop a life-saving treatment. This is a treatment that the patient connected with and that absolutely prevented them from getting sick, making them feel healthy. And not only that, the anxiety of the fear of transmitting the virus to their seronegative partner, because when you go off antiretroviral therapy, there is a risk of viral rebound and the risk of transmitting HIV to your seronegative partner. So it can be extremely stressful. And we need to reassure our patients that their safety will be our number one priority. And there are ways to mitigate those risks. And there are ways to protect the seronegative partners. The second impact that ATIs can have on the individual is of a physical nature. People, when they stop their treatment and they allow the virus to rebound, they can get sick from it. They can develop an acute retroviral syndrome, which is very reminiscent of how they felt the very first time they became infected with HIV. They can have fever, fatigue, they can lose weight, they can have night sweats, diarrhea, and so forth. Not only this, individuals who are at high risk for cardiovascular events, they can rarely develop an acute cardiovascular event because when their virus rebound, their inflammatory markers go up and they become a little bit more prothrombotic. They have a tendency to have really high risk of clotting. So it's very important to keep these things in mind. And more importantly, when people stop their antiretroviral therapy, there is a risk that their Cd4 count can drop. As we mentioned, HIV destroys those Cd4 cells and uses them to produce more HIV. As we know from studies, the median decline of Cd4 counts during the first 2 months after treatment interruption can be around 100 to 200 cells, but then it really slows down significantly down to 10, 15 cells a month. So that's very important, and we are on the lookout, and we are really monitoring this very closely, as you'll see in a second. The other risks associated with treatment interruption, when people go off their treatment, there's always the risk of them selecting resistance, especially if their drugs don't share the same half-lives. Not only this, when the virus rebound, there is a potential risk of the virus refueling more reservoirs. And also, as I mentioned earlier, is that when the virus rebound, the immune system kicks in, there is a war between the immune system and the virus, and there's a lot of inflammatory mediators that are being produced, which can be notorious to the system. What are the lessons we learned about the safety of treatment interruption in the real world? And I think one of the most important studies that really helped us understand the safety aspect of treatment interruptions, and in this case, open treatment interruptions, not analytical ones, which are really where patients are under more scrutiny, is the SMART study. And if you remember, the SMART study randomized patients who are fully suppressed on antiretroviral therapy to staying on treatment or going off treatment, and then restarting treatment on an as-needed basis based on their CD4 decline. And what we learned from the SMART study is that the rate of complications, the rate of adverse event, disease progression, and death was higher in those individuals who stopped their treatment compared to those who stayed on treatment, and the study was discontinued. And this is exactly why we don't recommend treatment interruption to our patient. But probably the most important lesson we learned is that when we looked at these adverse events, they didn't really occur during the first few months after treatment interruption. And you can see the rate of these adverse events start going up after 4 to 6 months from the treatment interruption, not during the first few weeks of the treatment interruption. And that also is true for the cardiovascular event that were noted in the SMART study. They occurred usually after 6 months and beyond after treatment interruption. So we know already that nothing terrible will happen to our patient when they go off treatment during the first few weeks of treatment interruption from this data. And not only this, there has been a nice meta-analysis looking specifically at adverse event associated with analytic treatment interruption, meaning those are interruptions that were conducted in cure-focused studies and where patients were under scrutiny. 42 trials, 1,597 patients. Only 6 studies reported adverse event. 2 major ones, one serious adverse event, which was death from a heart attack 15 weeks into the treatment interruption, 15 weeks. This is an individual who had to start with at high risk for cardiovascular event. And it was up until 15 weeks when they developed a heart attack that was, or could have been attributed to their treatment discontinuation. And there was 1 case of HIV transmission to a seronegative partner, also in a vaccine study. There were very few cases, very rare, 1 case of resistance, 1 case of acute retroviral syndrome, 1 case of low platelets, and very scattered cases of ill-defined complaints, non-major. So this is again underscore the safety, in a way, of an ATI when it's conducted under scrutiny. So this is exactly lead us to talk about the second and very important and paramount importance, which is the selection of our patient who will undergo these treatment interruption. The selection is critical. We tend to pick people who are healthy, and Lyndon is going to elaborate on this more, but it's very important to pick individuals who are healthy, i.e. they have very good CD4, healthy CD4, more than 450 or 500 at entry. Their CD4 nadir was always above 200, never dropped below 200, never had an AIDS-defining illness. They should basically be free of any cardiovascular condition, no chronic liver disease, no chronic viral infection, no uncontrolled diabetes, and so forth. Again, healthy individual, because we don't want them to really, we don't want their HIV rebound to tip them over the edge. And it's important to exclude individuals who are unwilling to use protection when they are sexually active with their seronegative partners during those treatment interruptions, nor are they willing to promote PrEP to their seronegative partners. So we have to take that into consideration to make it as safe as possible for the seronegative partners. And then the third phase is, how do we monitor ATIs? It's extremely important, and we will do this. The first rule in medicine is do no harm to our patients. So we will make sure and ensure that we keep our patient under the microscope. So we're gonna monitor their viral load weekly when they go off treatment. We're gonna monitor the CD4 every 2 weeks. We're gonna look for and survey any clinical symptoms that they may develop. And if it's attributed to their HIV rebound, very likely we'll put them back on treatment. And we're not gonna extend their treatment interruptions beyond 16 weeks, except in very rare situations. So we're gonna limit the duration of the treatment interruptions. And these are the antiretroviral treatment restart criteria. So when do we pull the trigger and resume antiretroviral therapy when we are monitoring people on ATI? Obviously, upon patient request, or if they develop any symptom that can be attributed to their HIV disease, i.e. fevers, lymph nodes, acute retroviral syndrome, night sweats, or if they drop their Cd4 count, be it more than 30% of their absolute count, all of these will trigger an immediate initiation of antiretroviral therapy. And more importantly, if their viral rebound goes above 1,000 and it remains above 1,000 through 6 weeks period, then we will reinitiate antiretroviral therapy. Now, the most important probably intervention in our studies that will mitigate the risk of treatment interruption is the fact that when we take our patient off antiretroviral therapy, we're substituting that antiretroviral therapy with a combination of two biologic agents, interferon on one hand and the broadly neutralizing antibody on the other hand, that I know Ken will talk about in length. But both of these biologic intervention that occurs naturally in the human body when fighting HIV or other viral infection is the fact that they both have an antiviral effect. So we're substituting antiretroviral therapy with two biologic agents that can also have an antiviral effect. And because of that, we expect during the ATI, at least the first phase of the ATI, we expect the patient to remain undetectable because we're replacing ARTs with those biologic agents. And interferon, as you know, is a signaling protein that plays a major role in fighting viral infections. And in this case, interferon really enhances the destructive power of natural killer cells, which are really part of the innate immunity. These NK cells are specialized to kill those latently infected cells which constitute the viral reservoirs. And then the broadly neutralizing antibody, think about them as GPS-guided missiles, which really are highly specific in recognizing HIV components. And what they do is that they track down HIV components and they literally neutralize them as soon as they latch on them. And we're going to be using two of those broadly neutralizing antibodies. The combination of the two, really finding and killing, is going to be tremendous in terms of maintaining viral suppression, likely, and also is going to be extremely important in impacting and destroying some of these latently infected cells in these reservoirs. And with that, that brings me to the conclusion of this section. ATIs are critical, and although they pose an ethical dilemma, we as clinicians, we can really make them safe for our patients by taking all the measures I shared with you. And there's a widespread, however, it's not a universal agreement among scientists, research regulators, clinical researchers, community-based advocates, and other stakeholders that if we carefully implement these ATIs, they are very acceptable and can be safe to our patients. And with that, I'm going to pass the baton to Lyndon, who's going to take us through the next part of the workshop.
All right, a little bit of musical chairs here. Oops. All right, so I'm the research program director here at FIGHT, and the number one question that I get from anybody interested in participating in research is, can I have an ATI? And my answer at first is always the same. It's, well, maybe, because what I have to do is I really have to get into somebody's like nitty gritty medical history with them. And Dr. Mounzer has really hammered the point home that this is all about safety. So I have to do a lot of digging to make sure that I find folks who are safe to undergo an ATI or participate in research that involves an ATI. So the first thing we look for are folks who are in a state of good health. Okay, great, Lyndon, that's pretty vague. What does state of good health mean? In this context, obviously that means folks whose HIV viral load is undetectable, but another really easy objective biomarker to look at is somebody's current Cd4 count. As Dr. Mounzer said, we want to see greater than 450, maybe even greater than 500 with some consistency, and folks never having a nadir, which is just a fancy word for lowest CD4 ever, of 200. So you want to see somebody that has consistently had a CD4 throughout their period of living with HIV of greater than 200. Some things that can be in somebody's medical history that would make them not a great candidate to undergo an ATI or participate in a study that's utilizing an ATI is anybody with a history of cardiovascular disease, that's heart and blood vessel disease, liver disease, and kidney disease. And you might be asking why. As Dr. Mounzer alluded to, we've learned from the SMART study and others that used ATIs that there's a higher rate of cardiovascular and kidney complications when patients go into a study that uses ATI already having these issues. Becoming viremic or having a detectable viral load again can put a significant strain on the body, and it can lead to needing further therapy or needing treatment where treatment wasn't needed before for your heart or your kidneys. And we never want to leave somebody worse off than when they started a study. Hepatitis B infection. Another thing to look out for, it's not a good idea to undergo an ATI if you have active hepatitis B infection. Many treatment regimens for HIV also contain elements that are able to suppress hepatitis B infection. And during a treatment interruption, we are taking those agents away. So that can cause somebody's hepatitis B virus to flare up and make their liver really sick. Hepatitis C co-infection is a little bit different, but that's because hepatitis C can be cured. So if somebody's approaching me and saying, hey, I want to do this study, I know that I might have to go off my HIV meds, I'm undetectable, I'm healthy, the only other thing is Hep C infection, my advice to them is hepatitis C is curable. Work with your healthcare team, get your hepatitis C treated and cured, make sure there hasn't been any damage to your liver, and we can then revisit at a later time. The next one, and I know it's probably like the weightiest one here for a lot of folks, is being a heavy smoker. A lot of people still smoke. Maybe this will help convince everybody to stop smoking, as we've been trying to do for years and years and years. But here's another really, really, really good reason. Heavy smokers may not be safe candidates for an ATI. I know Dr. Mounzer said this, but I really want to hammer the point home again. Heavy smoking can make people more prone to blood clots. This, coupled with the strain on the body during an ATI, could make some of the procedures that are associated with this research unsafe. I know Ken and Dr. Montaner are probably going to talk about this a little bit more, but there are procedures like biopsies and apheresis, which is a fancy way to get certain types of blood cells, but not take a whole lot of blood. And if somebody's prone to blood clots, that can be a really dangerous combination. Do we have to, are we having screen problems still?
Ask Linda to share her screen again.
Oh, did that just come through? Let's see, can I share my screen again? I'm sure I can share my screen again. Are we sharing again? Is that better?
You're all good.
All right, I'm gonna go back a couple of slides because I think things got a little messed up. That's fine. Technology's fun. Okay.
And thank you for bearing with us, London. This is part of
hey, yeah, whatever.
doing a digital conference, you know, unknown territory. So thank you.
At least this slideshow works. I presented my master's thesis with a slideshow where all of the formatting was wrong and I ended up just turning it off. So all right. So we were at, I know we didn't have slides, but I'm hoping that, you know, my explanation was good enough. I promise you didn't miss anything fancy. I didn't have awesome animation like Dr. Mounzer, sorry. Where we left off was just heavy smokers. They're at higher risk for blood clots, so it can make a lot of the procedures involved in ATI utilizing research pretty dangerous. Any uncontrolled medical condition, I have diabetes here just because it's really common in a lot of our patients, but uncontrolled diabetes or any uncontrolled medical condition, it's just too taxing on the immune system when you're faced with potentially having HIV viremia or a detectable virus. Again, the same thing for autoimmune diseases or cancer. And we're gonna move on. Maybe. There we go. Dr. Mounzer also touched on it, but it's very important. And so I want to reiterate that ATIs are not safe for folks who are unwilling or unable to use barrier protection or to promote PrEP for HIV protection with sexual partners who are HIV negative, or what we say seronegative. We spend a lot of time working with our patients to carefully educate them about safer sex practices during an ATI, but we also fully understand that relationship dynamics are often very dicey. If talking about using protection or changing your sexual habits with your partner can pose danger, an ATI might not be a great idea. We rely on our participants to share knowledge with partners. And if there's going to be a physical danger or danger to the relationship posed when somebody says, hey, we normally have sex this way, we need to change how we have sex for this period of time, an ATI study might not be best for you at this time. Like I said, we do a lot of careful education that, you know, we promote U equals U, undetectable equals untransmissible, but during an ATI, there is that potential that somebody will have detectable virus capable of being transmitted to a sexual partner. So we can only ask our consented participants to do XYZ practice. So we rely on them to take this information back to their partners, but we understand that relationship dynamics may not make the situation safe for everybody. Similarly, we would never recommend stopping antiretroviral therapy if you are someone who can bear children and wants to become pregnant. The same goes for those who are assigned male sex at birth and want to impregnate a partner. An ATI is not a great idea when you're trying to grow your family. Even more things to consider. There's so much thinking about undergoing an ATI. Dr. Mounzer talked about this, and I know Ken and Luis are probably going to talk about it later. There's probably going to be questions about it, but there's a lot of close, careful, and consistent, my 3 C's, monitoring of anyone who is off their antiretroviral therapy. Do you have time for all of that? It's a lot of blood work. It's a lot of visits to the clinic. It's a lot of phone calls, text messages, maybe some home monitoring, which is pretty cool, but also time consuming. Are there child or elder or family care issues? Is this going to get in the way of work or school? You know, we would never want somebody's participation to come between, you know, their means of supporting their family. I alluded to this in my last slide, but can I talk to my partner? Is it safe to talk to my partner? Has my status been disclosed to my partner? That's a huge thing, especially if we're not talking about a spouse or a life partner. If we're talking about somebody who does have sexual partners, maybe not consistently the same sexual partner, is HIV even discussed? Is it safe to change my sex practices to protect others? Do I have a support system? Participation in these studies can be time consuming. Like I said, there are a lot of appointments. Do you have support to get to and from the clinic if it's necessary? If there are issues with public transit, as we've all just gone through, you know, several times over the last few years, do you have support to help you get to your appointments? Or if the treatment is, you know, giving you side effects, do you have support to help you through that time, to help you call the doctor in an emergency or get you to a hospital? Do you just have moral support, somebody to give you a hug when you feel crappy? That's really important as you do these things and as you participate in studies that are new and take medications or combination therapies that are novel. Do you have the relationship with your doctor or your research team to know who to call if something goes wrong? That's also super important. And my last bullet point is also my question and my plea to anybody who wants to enter into ATI research. Have you been 100% open and honest about your health with your medical team? Do we know everything we need to know to keep you safe? This isn't, we don't trust you. This is, we need to know everything up front so we know when a change is happening that's dangerous. Speaking of staying safe during an ATI, I've said it 1,000 times, Dr. Mounzer said it, and I'll continue to say it 1,000 times. Careful monitoring and lots of it. During some studies, you may be asked to check your viral load as often as once a week. That's a lot. Nobody would ever do that. But when you're off ART, we want to know if you're becoming detectable or viremic again as soon as possible. Some studies would say, like, any detectable, any actual number, go back on your meds. Some want to, you know, establish a threshold, like 1,000 copies per milliliter, and see if people persist or do they go up and down. That all depends on the study, but we can't do any of that without careful and consistent monitoring. I know Dr. Mounzer brought this up already, but then, you know, talking about symptoms and keeping folks safe is really a two-way street. So we ask that any participants report everything. Tell us if you think you've lost some weight, or if you're having fevers or night sweats, diarrhea, something hurts that's never hurt before, something doesn't feel right, you're having trouble thinking, you don't have an appetite, tell us right away. We monitor things. I have drop in Cd4 here because it's just a great example. We monitor all of your labs. And if we see something, we'll tell you, but we need you to also talk to us and let us know when things are changing and things don't feel right. So I hope all of that information wasn't scary. So I thought it best now to bring back Andrea so she can tell you what the experience of an ATI was like for her during her participation. I'm gonna turn it over here. There we go.
Okay. Well, thank you, Lyndon. The one thing that I do have to say, dealing with Wistar Institute, dealing with Philadelphia Fight, I happen to have a good example of what informed consent is like. Because in some of my counseling sessions as a minister, I have something that I say to my clients. The very nature of fear is not knowing, but when knowing comes about, we kidnap the fear and make it disappear. And when you're in such a dire straits with your health, with not knowing, the only thing that you can do to maintain is try to get rid of the fear. And when the clinicians explain to you part by part what you're getting ready to endure, yes, it is an experiment. Yes, there are some uncertain things, but here are the certain things we know. Here is exactly what's going to happen. They help the fear disappear so that you can get to the root of what is necessary. And in dealing with an ATI, you have to be on top of knowing, because once the doubt starts to creep in, it can affect it tremendously. The whole project, your whole experience. What I would suggest to anyone who is thinking about it, as Lyndon stated, if you start losing weight or if you have a question, if you're in doubt about anything, ask, because that is what they're there for, to enlighten you, to actually educate you so that when you do put your name on that piece of paper, knowingly so, you fully understand everything that you're getting ready to partake of, everything that's going to happen to your body. And if some things start getting shaky, they've already had a plan B and a plan C to make sure that you're okay. That is one thing I like about my experience with Wistar and with Philadelphia Fight. But I would suggest to anyone, whatever agency you're using, whatever entity you are a part of, if you decide to be a part of an ATI, make sure any question you have, any doubt you have, you ask, because they will answer your questions. Then you can actually make an informed decision.
All right, next up is Ken to go into a little bit more about what cure-directed research is going on in Philadelphia right now.
Mute myself. There we go. Okay, good morning. Can everyone hear me now?
All good.
Okay, excellent. So first I want to introduce myself. My name is Ken. I am a registered nurse at the University of Pennsylvania, and I oversee the linkage between University of Pennsylvania, the Wistar Institute, and Philadelphia Fight. I'm down at Fight on a regular basis. I teach a class on this very topic within their Project Teach program, and I'm out in the community. So many of you may have seen me at different events, and I'm open to going to events to speak on this very topic. Wow, this has been a very intense discussion so far, and if this wasn't my world, I would probably be pretty scared right now and say, well, why would we even do this? You know, everything sounds so very concerning. And that's because it is a major decision to make to join a cure-directed research. But the question that the individual needs to ask themselves is, am I satisfied with taking one pill a day for the rest of my life? Is this good enough for me? Realizing that someone else asked themselves the same question when it was 3 pills a day, or when it was 5 pills a day, or 8, or 16, which all were a reality for someone in your past. And they said yes. They said it is worth it to push the envelope to reduce it from 16 pills, from 8 pills, from 4 pills, from 3, and now we're lucky to have 1. And now we ask the patient to ask themselves, are you satisfied with this? Is this acceptable for the rest of your life? Are you going to deal with the side effects of long-term therapy? There's always a give and a take. It controls your virus, but as we've seen over time, these medications do have unintended effects on the body. So this is a very personal question that each individual needs to ask themselves. Am I willing to push the envelope? I'm doing well now. Do I step out of what's comfortable for me and think about the community at large? Can we push this to a cure? Our friends in the world of hepatitis C would say yes. They've just within the last 6, 7, 8 years have enjoyed the transition from a disease, hepatitis C, which couldn't be cured or had very low incidence of cure. And now with a single pill or 2 pills for 3 or 4 months, we're at 99% cure rate. And I'm happy for the people who are dealing with hepatitis C. But now I'm thinking about my friends and my colleagues who are dealing with HIV, and I'm saying, now it's the time for HIV. Now we need to step up and put our energies behind HIV. So what I want to talk about at this point is about the exciting part of cure-directed research, why it's important, and that personal question. Not everyone who's listening to me may feel comfortable joining a cure-directed research project. That's okay. It's not for everyone. As Lyndon and Dr. Mounzer have already stated, we need a special group, the best, the strongest, because if we can't prove a cure-directed research solution in the most strong patient, the most likely to be successful, then we're certainly not going to be able to bring that solution and that cure down to the more complicated patients. So that's why sometimes we speak with people and they ultimately aren't eligible. It's not because of anything you've done. It's because the way research is done, you first need to prove it can be done in the ideal patient, and then we expand it down to more complicated patients. So if this isn't a project for you, you can become a community ambassador for Beat HIV. What do I mean? I mean, going into the community, into the various groups that you belong to, and sharing what you learned today. Share Lyndon's name and contact information. Share my name, my contact information. Direct people to our website, www.beat-hiv.org. Educate your fellow patients and citizens around that this is going on. If it just gives them hope, that was a success. If it motivates them to become involved, that's success. So while you might not be a candidate for the main study, by going out into the community and educating and directing people, you're helping. And then finally, there is also ways of giving one-time blood samples that the scientists at the Wistar Institute and other collaborating partners use for us to learn about HIV, and we're still learning about HIV, so that we can come up with future ideas, which will ultimately turn into a request for funding and hopefully a research project down the line. So there's many ways to get involved. It doesn't always have to be as a direct participant, although that is in what we're in need of right now in our current study. So now I'm going to go into some more specifics with regards to cure-directed research, what's involved in the clinical aspect. And so this is actually the 5th study that we have done. So that's something to take from home, to take to mind. When you're working with people, you're buying into the individuals who are running the study as much as the study itself. It's great to have an ideal to want to cure HIV, but do you feel safe with the team that you're working with? Do you feel informed? Do you feel valued? Your safety is far and away our #1 goal when we are conducting research. Knowledge at the expense of the safety of our patients is not satisfactory. And I know that it is the platform of all of us on the Beat HIV Collaboratory, Dr. Mounzer, Lyndon, myself, Dr. Tabas, who's the lead doctor at University of Pennsylvania, Dr. Montaner. Safety is far and away #1. And that's an important statement for someone to make to you, because before you go into something like an ATI, you want to feel like that you are the priority and that the research is secondary. And that's why I make it a point to say that to each and every participant who considers this. So we're building information that we've gathered from previous studies. So every time we do a study, we ask 2 questions, we answer those, and inevitably we end up with 3 additional questions. So the next study then poses and answers those 3 questions, and we answer those, and then it then gives us additional questions. And that's the nature of research. We're building on the information from before. So we're dealing with scientists from 8 institutions. We have 4 industry partners, the people who supply testing, they supply the drugs. And then the Beat HIV Collaboratory is seeking to develop a new combination for the first time, putting together the finding and the killing features of cure therapy. So we're using broadly neutralizing antibodies, which is the finding. It helps to find and identify these pockets or reservoirs of HIV. And the interferon, which is also a naturally occurring protein in the body, which motivates and stimulates the NK killer cells to go after those newfound little pockets. And in order to do this, we need to do the ATI, where we pull away from our traditional medicines and we substitute those with the investigational drugs, the broadly neutralizing antibodies and the interferon, where one churns up the immune system and gets it revved up, and the other highlights where these little hidden pockets are. So the only way that that can work with the ATI is to give the virus a false sense of security, so it begins to peek its head out of its hiding place, so we can identify and go after those. The reservoir is the whole reason we have a barrier to curing HIV. The medicines that you currently take keep the blood undetectable in the bloodstream, and that's great. But this little sneaky virus turns itself off and goes deeper into the body so that it can hibernate, and hopefully it wants to come out another day when your medications are no longer in place. So by doing the interruption, we wake the virus up. Simultaneously, we're stimulating the immune system and bringing the broadly neutralizing antibodies on board to lower or hopefully eventually eliminate the reservoir, which would then eliminate the need for the oral medications you take today. So that's kind of the framework. While the goal of this study is not to cure HIV in this study, the goal is to move us one step closer to a cure. And the ATI is central to that plan. So the next slide, please. Okay, so what's involved in this? How do we find out? How do the scientists measure our reservoir? How do the scientists in the study team evaluate our safety? And here are some examples of how that's done. So we have clinical safety labs that has already been touched on, are taken routinely, much more frequently than you would get during a standard of care, which you would expect. You're not in a standard situation. We're asking you to step away from a medication that you've built a relationship with. And as a result, we commit to following your blood lab results very closely so that we can guide your safety and keep you informed on what's going on. Now, I'm very proud to say that we've had approximately 100 people over all our times doing these research studies involving antiretroviral interruptions. And we've had no serious adverse events. Everything that Lyndon and Dr. Mounzer mentioned as far as risks and potentials are absolutely true. But equally as true that of all the people that we've done on our trials, under our close supervision and our plans, we have had no serious adverse events. That does not mean that somebody didn't feel crappy. That does not mean that someone did not have body aches. That did not mean that somebody felt nauseous. Those are baby adverse events that can happen with ibuprofen. I'm talking about serious adverse events such as hospitalizations, disability, death, anything seriously that affected the person in any kind of a permanent way. And so that's a very proud thing that the team represents, because it doesn't happen by accident. It happens through great planning, collaboration, close follow-up, frequent safety labs, and excellent relationships with our patients. As Lyndon said, we are not mind readers. We, in addition to your safety labs, we need people to speak to us and guide what we can do to take away these minimal side effects and keep an eye on any trends that may be going forward. Also involved is what they call a leukoapheresis. We often cut it down to just say apheresis. And an apheresis is a way for us to find the hidden HIV within the blood. It allows us to, through the use of a machine, target specific cells that we want collected from an individual. So it's a fancy blood draw. You would lay down, a needle would be placed in one arm and the other arm. Blood would cycle out through a machine, collect those specific cells, and then your own blood with nothing added back returned to you. It's a way of us targeting our blood collection with zero waste. Think of it as this: if I wanted to get the specific cells in the quantity I wanted, I might have to draw 20 tubes of blood, and then I would throw out 95% of what I've just taken from you. Through the use of an apheresis, the collection is done. We collect exactly what we want. We return all your blood back to you. Zero waste. So this is a much more safer way, with a respect to for the use of blood and respect to the patient, to collect the needed cells for our research while having no waste of product at all. Another way we evaluate the reservoir in the body is through biopsies. And in this case, it would be a rectal biopsy. Our immune system likes to hang out in certain spots within our body. And one of the favorite spots for white blood cells in our immune system to hang out when they're off duty is in the intestinal tract. The intestinal tract to the immune system is like the Las Vegas Strip. They're not on duty, they're sitting by the pool, they're drinking a nice cold drink and hanging out. So that's a great place if you as a researcher are trying to collect those type of cells to have access to. So we have a procedure that is somewhat invasive. It enters the body approximately 4 inches through the rectum. This is done by a qualified specialist at the University of Pennsylvania. And we collect microbiopsies of tissue from those areas in order to evaluate the reservoir at different time points within the trial. We often try it at the beginning to see where someone is when they came to us. We try often at the end of their therapy, the broadly neutralizing antibodies and the interferon, to show what change has happened after our idea was implemented. And then the third time would be 6 months after the experimental strategy was completed. And the question we're asking there is, if there was a change, was the body able to hold on to that change? Frequently, people are very concerned about this procedure, but after they've undergone the first one, they often say to me, you were right, Ken, that it wasn't as big as a deal as I thought it was going to be, that it wasn't painful, it was uncomfortable upon entry. However, we don't have nerve endings within our intestinal tract. So when they're taking those little micro pinches, which is about the size of a tip of a pen where you write, they didn't feel it. However, the information that's contained in that tiny little piece of tissue is is priceless to the research team and is shared many, many times over with various people within the team. So these are an example of different types of procedures that are involved in an HIV cure research project. Some are meant for safety and some are meant for knowledge. If you're interested in the trial and you go further to inquire, obviously there's much more information about these, how it's done and possible risks, but this just gives you a taste of the procedures that are involved in a cure research project. Next slide, please. Okay, so as Dr. Maelzer has already said, we're asking for an analytic treatment interruption, an ATI, and then so how that works is initially we start with the interferon while you're still on your medications. It's called a loading dose. So for 4 weeks, you'll still be on your medicine, and the interferon, you'll get a small baby injection, size of a half-inch needle, very painless, into the little fatty area of your stomach. And we put that on board for 4 weeks while you're still on your medication. That's called a loading dose, so that is already on board. Then we ask you to stop your oral medications, your antiretrovirals as you normally take, and then we bring the broadly neutralizing antibodies on board, and that's done through an infusion. By infusion, I say that a bag is hanging next to you. You'll have a needle in your arm and it'll drip in over a 30-minute period. There are 2 different antibodies that we're using. So those would be given separated from each other so that we could tell if you had any side effect, which one of those was the agent that caused you to have that side effect. So this can involve sitting in a chair for a few hours, simply playing on your phone, closing your eyes, and the medication would drip in. So that's what we refer as an infusion. So while it is scary to let go of this antiretroviral that you've built this relationship and trust with, as Dr. Maelzer said, we are replacing them with other antiretrovirals that we believe and other studies have shown have controlling attributes. So we're not anticipating your viral load to spike up, but that doesn't mean we're not going to follow it. And we're going to ensure that everything goes as we had planned. So it's not like you're going off medication and having nothing. You're going off your traditional medicines and replacing it with these investigational medicines, both of which have been shown to be safe within the human body. Interferon is already approved for use. It used to be used in hepatitis C. It's no longer a medicine used for that, but it's still safe for use, and the FDA has given us permission to use it. And the broadly neutralizing antibodies have been studied with minor side effects and have had great success with controlling the virus. So this is the first time that we're putting 2 strategies together. And it's kind of like the old commercials that used to come out with Reese's peanut butter. You had this one guy who loved his peanut butter, and you had this other guy who loved his chocolate. And then inevitably they bumped into each other and they got chocolate in my peanut butter. No, you got peanut butter in my chocolate. So this is a novel approach that's never been done before, and it's being done here in Philadelphia, and it's an exciting time for the right patients. And so the key for us is to educate, share, be totally transparent, and find those right patients. A total of 21 individuals from the Philadelphia area. And we'll recruit above Philadelphia into Jersey and into Delaware as well. So this whole circle area, as long as they can come to us so they can be followed closely, we will enroll them in the study if they meet criteria. So this is an exciting time, and we do already have people lined up, but we need more to come to us because we need to speak to 4 people typically before we'll find one that matches the criteria. And that's both for the integrity of the science, but also for the safety of the individuals. So that's something to think about. We need to speak to 4 people in order to find one, and then that person still needs to go through their own personal reflection on whether a cure study is right for them. Okay, next slide, please. Okay, so here are some of the side effects. Like any drug, some of the agents that we're proposing to use will potentially have side effects. Now, interferon is known on the street in its history as a hepatitis C drug. And very often people will have an exchange like, wow, my sister was on that and that was a really messed up drug. She felt horrible. She did this. And I've been dealing with those kind of conversations since we've been using interferon for the last 3 studies. So I can tell you what I've seen in our last 3 studies. The interferon for hepatitis C was being used in someone with a sick liver. It was being used for an extended period of time, 1 year, and was being used in addition to another medicine that individual was taking. So to use a hepatitis C person's experience with interferon as an example would not be fair, because the individual had their own condition and it was taken for a longer time with another agent. Interferon, but we are stuck with the labeling, and this is what is shown on the labeling, that we have to monitor closely because interferon in the past has shown mood change, headaches, flu-like symptoms, tiredness, loss of appetite, anemia, or low white blood cell count. Now, that's not to say that everyone will have all those. In fact, it's very, very, very unlikely that anyone would have all those symptoms, but those are the common symptoms that are reported, and some are more common than other. I can tell you that the folks who've taken it, especially when they're first introduced, often have feeling of tiredness, often have flu-like achy symptoms, and they can often be resolved with something as simple as ibuprofen over the counter. However, these things have been reported when they were studying interferon. So we do, to be transparent, need to let you see the entire list. But I like to put an asterisk next to that and say that typically our patients with HIV who are taking interferon do not have the most severe of these side effects, and that are typically worse when they start and then begin to wean off. But it's true for anything that we put into our body, the yin and the yang. When you take something to fix one problem, often you can end up with another issue. So these are, in fact, some of the issues that have been known to be with interferon. However, my experience with 60+ patients with interferon is that they tend to be on the more mild side and the less severe of the side effects. But you should be aware that any one of them are potential, just as Dr. Mounzer and Linden had outlaid on other areas. We have to make you aware of all the potentials and then give you the real world of what I have seen. Next slide, please. Okay, with blood neutralizing antibodies. So there, as I mentioned, there's 2 different sets of antibodies, and there's a total of 7 infusions over the entire study, and they're separated between 2 to 3 weeks, depending on where you are within the study. And so this is the part that helps. This is your normal body function. Your body makes antibodies in reaction to an antigen, no different than when you get a vaccination for the flu. You get, we get the body's response is to make an antibody. And so this is an antibody to neutralize HIV. This is something that's made in the lab and is not something that the body makes. But these are the potential side effects associated with that. It's been generally well received: mild headache, fatigue, muscle aches, no serious adverse events. Again, these are on the mild side and usually happen at the beginning of an introduction of an idea and then wean after that. But again, these are listed as possible side effects related to broadly neutralizing antibodies. Next screen. As I mentioned before, if a full study is not for you, another way to become involved is to get in contact with Lyndon or myself and put yourself on a list for potential one-time donations. So if you're not ready to commit to a full-fledged study, but you say, I want to help in some way, donating blood, which is used for HIV research, is one way to do that. So here also is another time where Lyndon and my contact information is listed. And if you wanted to be interested in a one-time blood donation or a recurring blood donation, this would be a way to start that engagement. Next slide. Okay, there is one other study that we're not recruiting for directly that we'd like to give a shout out to. It's under the umbrella of Beat HIV. It is engineering T cells. So they collect some blood from you through the apheresis. They adjust those cells to give them some kind of a superpower by either removing or adding something to your cells, and then they return your very own cells back to you and look at the new cell's ability after the reservoir in another approach for cure HIV study, to reduce the reservoir to cure HIV. So the contact information for if anyone's interested in a T cell engineering T cell study would be Eileen Donahue, and her phone number is 215-349-8092. That is under the it's under the umbrella of Beat HIV, but this is not actively being recruited by myself or by Philadelphia Fight. So that would be contacting Eileen directly. Next slide. So I wanted to emphasize that none of our research can happen without the community, without people taking times out of their lives to come and meet with Lyndon and I, to donate their time, their blood, their tissue, their testimonials, and we appreciate everyone who takes the time to do that. All of our past patients, 100 plus and ongoing. And we also have a community advisory board as pictured here on the far right side. These are folks from the community who advise us on making sure that we're in tune with the community, then what we're asking people to do and how we're approaching it is correct. So they're Jiminy Cricket to us. They give us valuable information on how to proceed to reach different parts of the community and how to stay in touch with what the community wants out of their research. They've been very active. They've written a position paper. We have one of the strongest cabs within the Delaney HIV funding group. We have a model that people want to emulate, and we are actively seeking members for the community advisory board. So if you have another way to participate would be to potentially be part of this community advisory board and help to make sure that the message of the community and we stay in touch. So if you have any interest in that, feel free to reach out to me, and I would be happy to put you in contact with leadership at the CAB so that you can see what it's about and potentially join. So that's great. So we thank everyone, our community members, as well as our past participants. Next slide. So here's just finally a really quick snapshot of contact information. The first is the Beat HIV website. Second is Philadelphia's information, Philadelphia Fight's information regarding their programs and research on hand. Again, my contact information. Email is the best way to get me. And then also you have Lyndon's information. That's her direct line to her, as well as email for inquiring about research projects at Philadelphia Fight. Thank you for your time. So we're going to open it up to questions at this point.
Wonderful. Thank you so much, everyone. I'm just going to unmute everyone because we do have a few questions coming in. I just wanted to thank everyone for providing science, context, history, and, just a little bit of insight into the work that you are all doing. We have a few questions coming in, so I'm just going to go ahead and read those and leave it open to anyone who would like to answer. So our first question asks, what are the tools that peer educators and community health workers have to promote the project as they do trainings in the community?
Videos. Check out the videos. We do have in Beat HIV, and perhaps we should try to put them on a Fight Research website as well. 4 videos that we generated last year. And I think this session would also be recorded and accessible. So between the videos that we produced, explaining Cure research, explaining treatment interruption, explaining what is it like to be in a study, together with this session and the feedback directly from Lyndon and Ken and Dr. Mounzer, I think all of those are resources that are available.
As well as calling your friendly neighborhood researchers to come to your organization and give like an in-person talk. I know Ken does this all the time, but that's something, he and I both can do. So if you have time, if you have a scheduled meeting, we can always drop in with materials, with slideshows, sometimes snacks. We can help.
Absolutely.
Wonderful, thank you. And just to the audience, I wanted to just remind you, all resources for all of our webinars, including this one, will be compiled after the conclusion of the summit, and we will let folks know when those resources are available. So thank you. Our next question, starts off with a statement. Andrea, I love your poetry. So Andrea, I just wanted to let you know.
You've got a fan.
Yeah, you have a fan. And then the question is, for Ken, are any cure-related studies recruiting HIV negative people?
Well, those type of studies are usually either related to PrEP or vaccine. And I'm happy to make a referral to a colleague who is responsible for recruiting for NET. Her first name is Annette, A-N-N-E-T. Last name is Davis. And I would have to look up her phone number, but before we're done with our talk, I'll have Annette's phone number. So if anyone who is HIV negative and interested in participating in vaccine or PrEP, they can reach out to Annette.
And also, if you're interested to donate just regular blood for research, Wistar has a phlebotomy program where we recruit donations that are used by the Institute as a whole. And we certainly, in our work on HIV, use samples from persons that are not HIV positive as comparisons to the groups that we recruit that are have different conditions. So we're also interested to have those participate.
As well as clinicaltrials.gov, it's a website access, is open to anyone, and you can search by research topic area, you can search by your location in the country, and that's a great way to find the contact information and sort of self-refer to studies that you think you might be interested in if, this has given you a little bit of motivation or the bug to participate in any type of research.
And I do have Annette's phone number now. The update for Annette for HIV negative research would be 215-746-7357. And again, her name is Annette Davis.
Thank you, Ken. And if you joined us last Friday, you all would have met Annette. She gave a great presentation on the research being done around PrEP and cisgender women. So thank you for making that connection, Ken. And Lyndon, can you say the name of that website one more time? It's
clinicaltrials.gov. I know I speak really fast when I get excited. All one word. But that's something I recommend, not just flippantly, if people want to do research at FIGHT and maybe they don't quite meet our criteria, I always help folks advocate for themselves. And that's a great way to, knowing your personal medical history, to go on whenever you have time, see what's out there for you. And you can make the calls when you're ready. If you find studies that are recruiting that you can easily access, you can make the call when you're ready.
Thank you. Thank you. I am personally a big advocate of always seeking out follow-up resources, seeking out correct information. And with that, I just want to ask the whole panel and address the elephant in the room. I think the work that you all are doing has kind of a new audience, so to speak. People are hearing words like clinical trials or vaccine research, thanks to COVID. That language and that talk is in kind of the public health zeitgeist and in the mainstream media now. With that new audience, where do you suggest folks who may have no clue what is being talked about, where do you suggest that they go for clear and supported and correct information?
Well, can I speak as one of the community members? What I would suggest, if you have a doctor, you just ask a simple question. Where? How? If they don't have the answer, they will at least be able to point you in the right direction. If you don't have a primary care physician, community center, ask. Word on the street, ask. A closed mouth will not get fed. Just ask.
Thank you for that, Andrea.
I always ask, tell people, I hope that you are comfortable enough to go to your primary care physician. If you have questions about research, now dealing with COVID, if you're just wondering what is accurate about COVID itself, not just about research, I always hope that folks have that relationship with their primary care provider. Just ask, just like Andrea said, just ask.
Yeah, and I really appreciate the efforts you all personally make to create that kind of conversation with the folks that you work with, and keep that line of communication and keep it honest and, in relatable, accessible terms. So I just wanted to name that as well. We have one more question, and they asked, in the past, interferon had some serious side effects when treating Hep C, e.g. depression. I guess they're asking, are there serious side effects?
Well, I can speak to that one because I've gone through the treatment. And one thing I can say, if you are thinking about the study, what you should definitely do is make sure you have a support base. Make sure you have situated people around you that can help support you mentally. Because yes, you will have some days where you get mood swings and things and you may feel unsure or sad, but as long as you actually have some people in place that can support you, ask how you're doing, check in with you, and you can go to them to lean on, it will make it so much easier for you and you won't be trying to muddle through.
Yeah, it's very important.
I would, okay, go ahead.
No, Ken, you were going to say something?
I was going to say that is absolutely correct, that the potential list of side effects from interferon does include depression. It has not been our experience that it has been anything severe beyond moodiness or feeling short-tempered at times. And of all the people we've had on our studies, we've never had anyone either be removed or remove themselves associated with the side effect of depression.
Yeah, and I will add to that we are screening our patients, and among other things, we're looking at their depression score. Patients with major depression prior to, will be practically reconsidered and possibly excluded from an ATI study, and specifically for that particular reason. And if they do mount a mild exacerbation, we will work very closely with them. And there are many things we can do to address that. But again, you're absolutely right, Kyle, that those with major depression, folks with suicidal ideation, history of suicidal attempts, bipolar, may not be the best candidates for this kind of like phase one of our effort to really understand the impact of this combination of interferon and protein neutralizing antibody on latent reservoirs.
And we use a tool, a paper-based objective measure called the PHQ-9 to monitor folks throughout their participation, particularly if they are receiving interferon, because mood changes, specifically depression, are a known side effect. So I understand that sometimes mood changes might not just be sad and crying. You might feel irritable, you might have lack of focus, and that's why we incorporate this objective measure. Maybe you weren't thinking about that as potentially, related to this study. But then when you sit down and it's just you and your thoughts and you're checking the boxes, and all of a sudden you realize, maybe this is an issue. Now we have a launch pad. Now we have something that we can use to talk about and say, hey, when did this start? How bad? Has it ever been this bad before? What was your life like then? And we can bring in either the study doctor, so whoever's running the study at the health center. We can reach out to the patient's primary care provider if that's appropriate, or they'll allow, or we can bring in other mental health resources. The beautiful thing about FIGHT being part of this work is that as an organization, we have mental health resources available to us.
Thank you for that. So it definitely seems like you provide kind of a holistic support system to the folks who are going through this process, and you hold them up and guide them. So I want to thank you for providing that context and information. So it looks like we're just about up on time. I just wanted to leave the floor open to anyone who wants to leave us with any closing thoughts before we end today's webinar.
I would love to use this opportunity to just reinforce that we are actively recruiting for Beat HIV 2, which is the curative HIV study that is being done at the University of Penn and Philadelphia FIGHT, everything we've been speaking about. And we've only given you an appetizer of information. It's obviously a longer conversation, but if this has sparked your hunger to learn more about HIV cure, we invite you, if you're a FIGHT patient, to please call Lyndon directly at 215-525-8695. Or I invite you to call me if you are cared at University of Pennsylvania or anywhere else at 215-662-8217. We need the community support in order to move this forward, and we're under tight time constrictions due to COVID. So our time has been tightened, so we need our community support more than ever.
And I'm a total nerd. I'll talk your ear off about research, about anything health science, about this particular line of work. I am happy to do so.
It takes all of us. So I hope that you got a lot from this, and we all contribute from different directions. And I think the whole goal is that coming together, we will make a difference. So I hope that you join us on that path.
All right.
Right. And with that, I just wanted to thank you, Andrea, Dr. Montaner, Ken, Dr. Mounzer, and Lyndon. I wanted to thank you all for joining us today and providing our audience with wonderful information and a peek into the work you all are doing. And to the audience, thank you for coming today and joining us once again for our third week of the HIV Prevention and Education virtual conference. Have a good day. Be kind to yourself and be kind to others. Thank you, everyone.
Thank you.
Thank you.